Hello guys, welcome back to Coco Canvas. Today, let us look at the heavyweight champion of the skeletal system, the longest, the strongest, and the heaviest bone in your body, the femur. A bone so tough that it can support up to 30 times your body weight. If you want to remember the order of the lower limb bones, just think from pennies to fives, they may pay. It means femur, patella, tibia, fibula, tarsals, metatarsals, and phalanges. Now, let's start with the femur. Let's start at the very top. The head of the femur. The head is a smooth sphere that fits into the acetabulum of the pelvis. It has a tiny pit called the fovea capitis, which is the attachment site for the ligament of the head. Next is the neck, the most vulnerable part of the bone. Let us look at the bumps. The greater trochanter is lateral and large. It serves as the attachment for the gluteus medius, minimus, and piriformis. The lesser trochanter is medial and smaller. Here's where your chief hip flexor, the iliopsoas, inserts. Connecting them on the anterior surface is the intertrochanteric line. This serves as the attachment of the strong iliofemoral ligament. Posteriorly, you will find the intratrochanteric crest, which features a prominent bump called the quadrate tubercle for the attachment of the quadratus femoris. Another name for quadratus femoris is square femoris muscle. Alright, let's move on to the shaft, the pillar of strength. The shaft is slightly bowed forward. On the posterior side, you will see a rough, raised vertical structure known as the linea aspera. Now, the linea aspera splits into two. The pectineal line on the medial side for the pectineus muscle and gluteal tuberosity on the lateral side for the gluteus maximus. Once again, linea aspera splits into two, pectineal line on the medial side for the pectineus muscle and gluteal tuberosity on the lateral side for the gluteus maximus. Distally, it fans out to form the medial and lateral supracondylar lines, creating a flat triangular area called the popliteal surface or popliteal fossa. So, let me give you a very high yield attachment alert here. Remember the mnemonic AM-SO, A-M-S-O, AM-SO, which basically means adductor magnus is a dual agent supplied by both sciatic and obturator nerve. Dual agent supplied by both sciatic and obturator nerves. Let's move on to the distal end, the knees foundation. At the bottom, the femur expands into massive landmarks. We have the medial and lateral condyles, which articulate with the tibia. On top of these sit the medial and lateral epicondyle. Right, so at the base you got medial and lateral condyles. On top of them sits the medial and lateral epicondyle, which means above condyle. Now, keep an eye out for a few distal landmarks. Adductor tubercle, a specific bump on the medial epicondyle where the hamstring part of the adductor magnus attaches. Then we have the intercondylar fossa, the deep notch in the back between the condyles. This is where the ACL and PCL attach, anterior and posterior cruciate ligaments. Next, patellar surface, a smooth groove in the front where the kneecap or patella glides. Now, let me give you a clinical pearl. In distal femur fractures, watch out for popliteal artery. It sits in the intercondylar area and can be easily nicked or crushed. Okay, so popliteal artery sits in the intercondylar area. It can be easily nicked or crushed. So just think of it if you see a case of distal femur fractures. Now, let us look at some clinical rounds here. Femoral neck fracture, you see if it's laterally rotated, it has a high risk of AVN, avascular necrosis. Why? Because it is the disruption of the medial femoral circumflex artery. So, femoral neck fracture, if it's shortened and laterally rotated, you see AVN due to disruption of medial femoral circumflex artery. Next, posterior hip dislocation. Here, the leg appears to be shortened and medially rotated. Remember, for femoral neck, the leg appears shortened and laterally rotated. However, for posterior hip dislocation, the leg appears shortened and medially rotated. Can cause fractures of the femoral head or sciatic nerve injury. One more thing, it's not very important, but you have something known as SCFE. Slipped capital femoral epiphysis. It looks like a scoop of ice cream falling off a cone on X-ray. So, if you look at an X-ray and it looks like an ice cream that's falling off its cone, just think of SCFE, slipped capital femoral epiphysis. Alright, I guess this was great. There is a small picture here that might help you remember some of the landmarks which we have learned. And this is the real bone. Alright, I hope you're able to study this. Head for the socket, neck in the line of fire, linea aspera for the muscles, condyles for the knee. And if you're going to do a procedure in the groin area, remember navel. From lateral to medial, nerve, artery, vein, empty space, lymphatics. Study the landmarks and be a good student. Take care.